So upon the completion of these sessions, you are expected to define a few terminologies in pregnancy, like describe the stage of fetal development, and you should be able to describe the physiological changes during pregnancy and their impact on pharmacokinetics of the drugs, and you should be able to identify different teratogenic agents and drug of concern during lactation. And apart from that, you should be able to in a position to formulate a treatment outline for common condition in a pregnant and lactating woman. So those are the objectives of today's session. So before that, let us talk about a few terminologies about pregnancy. So remember, pregnancy or gestation is a maternal condition of having a developing fetus in the body. So most of the time, the gestation period is about like between 37 to 42 weeks time. So it is approximately lasts like 28 days. So this is normally like the period of normal term. But beyond that is actually post-term. So they're supposed to induce normally delivery. So most of the time, this gestation period is usually counted from the first day of the last menstrual period. That is how we are going to calculate the gestation period. So what are the basic terminologies that is commonly used in the gynecology world, like gravida, gravidity, multigravida, nelligravida, nellipara? Those are the very common terminologies you are going to hear from the history, especially when you see a female patient. So gravida means it is a woman who is pregnant. Gravidity is the pregnancy itself. Multigravida means like a woman who has completed two or more pregnancy to the stage of fetal viability. We'll discuss later when do we say like the fetal viability age. When you say nelly gravida, it is a woman who has never been pregnant before. We call it nelly gravida. But when you say nelly para, it is a woman who has not completed pregnancy with a fetus or fetuses who have reached a stage of fetal viability. So the difference between the two is actually like those nelly para, they have not achieved the stage of fetal viability. They might be pregnant at some point, but they have not reached to the stage of fetal viability. That's the difference between. So when you say nelly gravida, means a woman who has never been pregnant before. Yes.
Can you say the Nalipara women are the ones who maybe had a miscarriage?
Yeah, yes. The nilparia one is the one who has actually miscarriage, but that miscarriage should be like before the stage of fetal viability. I will come later. The only difference is actually the two, but this one is like like before the stage. So miscarriage is actually still under nellipara. But anyone who never pregnant by before is nelly gravida, but nellipara might be someone who are actually even aborted before, like before the stage of fetal viability. Okay, then continue to the basic terminologies, like there is also post-term. So this post-term refers to like the birth of an infant after 40 weeks of gestation. In fact, this is a very common condition. That is why most gynecologists, like if the infant is not delivered by the age of like 40 weeks time in the uterus, now they're supposed to induce or they maybe do cesarean section. So those are the only strategies, and it's very common condition. And then sometimes even like the fetus can be born like before completion of like it is gestation cycle. We call it like preterm labor. In fact, this is really very hard even for the mothers as well as the parents in general, because like the fetuses or the infant is supposed to be like in incubation sometime. Most of the time the organs are not matured very well, so the probability of survival is very questionable in case of preterm labor. But anyways, an infant who is born after the 20 weeks of gestation but before completion of 30 weeks of gestation, we can say it is a preterm labor. But before that, we call it even miscarriage because the fetus is not really like even, it cannot even survive. Then gravida is a woman who is pregnant for the first time. We call them gravida. Then when you say para, it is a woman who has completed one pregnancy with a fetus who have reached a stage of fetal viability. So this is normally like when the mother reached to the stage of fetal viability, we call it para when it is one. Then when you say term, it is like the normal pregnancy period. So like the infant was born between 38 to 42 weeks of gestation. We call it like the normal term period. But when do we say, or what is, which age of classification is like the fetus is actually viable? Remember, viability means the ability of the fetus to survive outside the human uterus. So, like most of the time, or different evidence showed that if the fetus is actually having the age of 22 to 24 weeks since the last menstrual period, the probability of like fetal viability is very high. But below that period, like after this, below these weeks of gestation, mostly like the lungs are not matured, the brains are not matured, the kidney are not working properly. So the possibility of survival is questionable and it is very, very unlikely. So in case of even preterm, we can actually even say the fetus can be viable is only when the age of the fetus is actually between this age of gestation period. Otherwise, the probability is not possible. So let me take you through about the physiology of pregnancy. Remember, fertilization is the first thing that comes to in our mind when you are talking about pregnancy, and usually occur by the union of the sperm and egg, which is very common, and it occurs in the fallopian tube. Remember, fertilization occurs in the fallopian tube. Like during ovulation, the eggs will be like from the ovary will be released to the fallopian tube for fertilization. So now the fertilized egg normally will like travel down to the fallopian tube like for 2 days, like with cell division taking place. So by day 3, what will happen? The fertilized egg will reach to the uterus. It is actually like rolling down to the fallopian tube to reach to the uterus for implantation. Then after that, the cell division will continue like for 2 to 3 days in the uterus cavity before implantation. So after reaching to the uterus, it still undergoes cell division before implantation. So this period, we call it the critical period of human fetal development. So this is normally a process whereby a baby develops inside the mother's womb. Conventionally, this critical period is divided into 3 trimesters. Like one trimester is equivalent to 3 months. So, and the total duration it will take is like 37 weeks. Some literature says like 38 weeks anyways. So the primary stage of prenatal development can be classified into 3 major categories: pre-embryonic period, embryonic period, and fetal period. But the essence of actually talking this point is not to discuss about like the fetal development, but this is just actually to discuss about the risk of drug exposure during this fetal cycle. So what is actually expected from the pharmacist, especially in managing any teratogenic material during fetal development, is very, very important. So we have to know what will happen if a mother is exposed to a certain teratogenic agent during the pre-embryonic period, and what will happen if the mother is exposed to any teratogenic agent in the embryonic period as well as in the fetal period. So the anatomical malformations are actually varies depending on the stage of the fetal development. So when do we say the pre-embryonic period? Remember, from the day of fertilization to like the first 2 weeks from the day of conception, we call it the pre-embryonic period. So this is actually describe the period up to the implantation of the fertilized ovum. So the period from the fertilization up to implantation to the uterus is known as pre-embryonic period. So this period is actually in the first 2 weeks of development. It is very critical. So what will happen? What will happen if the mother is actually exposed to a certain teratogenic medication during this period? The probability of having a spontaneous abortion is very high. So remember, during this period, like the zygote will actually is already developed, so it moves along the fallopian tube toward the uterus, and it will attach. So now the zygote becomes like after like implantation, we call it is blastocyte. So this blastocyte or the germinal period or the pre-embryonic period will end when the blastocyte is actually fully implanted into the uterine tissue. So after fertilization and actually like rolling over to the fallopian tube, sorry, to the uterus to implant, then that process is actually, we call it pre-embryonic period until like the uterus is actually fully, until the blastocyte is fully implanted to the uterus. So in short, pre-embryonic period is the duration from the conception until fully implantation to the uterus. So if there is a drug exposure, spontaneous abortion can happen. So generally speaking, fetal malformation, especially in terms of like organ malformation, is very likely during this period because organ development has not yet started during this period. So the only probability of occurrence is like miscarriage or abortion can actually happen in case of drug exposure. But sometimes some drugs which is having like longer half-life in the body system, they can actually even extend their activity into the embryonic stage and it causes some kind of malformation into the organ. Unless in otherwise, the probability is very unlikely to occur. Then the second stage of fetal development is we call it embryonic period. So this is a period which lasts from the implantation until week 8 of gestation period. So remember, this period is very critical. So this is the period whereby majority of the organs normally start developing, despite like the CNS will actually like the teeth is usually formed around week 10 of gestation period. But generally speaking, organogenesis usually occur during this period. Then they continue to grow and mature during the fetal period. So this is a period whereby we need to be very cautious about the drug exposure for pregnant mother because this is a period we are going to see significant organ malformation if there is an exposure to a certain drug substances. This is a greater risk, and the possibility of having major birth defect is very high. So generally speaking, it is advisable for a mother to avoid any drugs during this period whenever possible. So the general principle of treatment of like condition in pregnant mother. So as long as if it is possible, try to avoid any pharmacological modalities in the during gestation period. But this is true whenever possible. Otherwise, what you can do is you have to choose any drug that can manage the condition of the pregnant mother, but you have to select a drug which is very safe during pregnancy. Then that is the home take message. Then the next step of fetal development is like from week 8 up to birth. Like from week 9 up to birth is known as the fetal period. So this is the last phase of the development of the fetus. Remember, during this period, like the organ will continue to mature. Yeah, that is very common. And still, the fetus is susceptible to some drug effect. But mostly here, the organ is already formed, and malformation of the organs is very, very likely. So what will happen here when a certain drug molecule is exposed to this fetal period? Now you are going to see fetal growth restriction and functional deficiency, such as mental retardation, renal insufficiency can happen. So mostly organ dysfunction or functional deficit is the most common teratogenicity effect that can be observed during this period. So this is a summary of what I have said before, like the different phases of fetal development, and you can actually even read on your own time. In the first phase, spontaneous abortion can be happen. Second phase, mostly we are going to see structural anomalies. Within the last phase, mostly we are going to see fetal growth retardation and functional deficiency of the organ can happen. Okay, then. So this is all about the different phases of the different phases of fetal development. Now let's see about the symptoms of pregnancy. So what are the signs and symptoms of pregnancy? So the signs and symptoms of pregnancy usually varies depending on the trimester. So in the first trimester, that's the first 3 months of pregnancy, especially in the first few days after implantation or after fertilization, there is a possibility of like light spot of blood in the genital areas. So those are not really menstruation, but those are indicators of early. It is quite different from the menstrual period, but it is just like slight spotting in the genital areas. So it is very common during the early phases of pregnancy. Then most of the time the ladies will actually miss the menstrual cycle. That is very common. Then apart from that, they complain tenderness of the breast, and not only even tenderness, even engorgement of the breast is very common, and also increased urination, mood swing, nausea, vomiting, headache, heartburn, and constipations are very common presentation. So those presentations, especially like the breast tenderness, the mood change, nausea, and vomiting, is mostly uh, associated with like the mood swing, nausea, vomiting is mostly this one is actually because of the production of ACG by the placenta. Remember, after sexual intercourse, the probability of detecting pregnancy is usually in the first 12 days or maybe in the 2 weeks time after sexual intercourse, because that is like for the human HCG to appear in the urine sample or in the blood sample, it usually takes a minimum of like 12 weeks. But remember, some person or it can actually even detected as early as possible, like in the span of 4 to 5 days. But mostly the average time of detection is usually 2 weeks time. So that is when you are expecting to have pregnancy or like detection of pregnancy from the serum and urine sample. Mostly urine sample is very easier to track, but sometimes when the urine sample is not like, if you are not actually very sure about the urine sample result, maybe you can check the HCG level from the blood sample. Then the heartburn and constipation is mainly because of the progesterone. Progesterone normally it will actually even lower GI motility, so constipation can happen, and also even it actually relaxes the lower esophageal sphincter. So there is a possibility of acid reflux to the esophagus and it causes heartburn sensation. The edema is mainly due to the effect of estrogen. Estrogen normally activates the renin, angiotensin, aldosterone system and causes fluid retention. Then the linea nigra, we call it the pregnancy line, which starts from the pubic area up to the umbilicus. But sometimes even it can go to the upper part of the abdomen. But mostly it starts from here, that is the pubic region, up to the umbilical region. So there is actually darkening. I think this one is very common, and most of even most of our parents will know this is most common pregnancy line. So this pregnancy line is actually as a result of the estrogen and progesterone to increase the production of melanocyte, so that this melanocyte can cause darkening of the skin. But not only in this area, by the way, the darkening of the skin is generally very common even in the trunk areas, which is very common during pregnancy. But generally, this darkening of the skin will go away after delivery. Then another symptoms of pregnancy is nausea and vomiting. So what causes nausea and vomiting is actually the HCG, which is produced by the placenta. So when HCG is produced, now it can actually produce, it can cause or activate the vomiting center. But mostly, it usually resolves after 14 to 16 weeks of gestation. So what is very notorious to pregnant mother is actually the nausea and vomiting. So most of the time, it will actually disappear, very common in the first trimester of pregnancy. Then apart from that, when the pregnancy is actually like when the duration increases, they are going to see like the fetal movement in the lower abdomen. They are going to feel the fetal movement in the lower abdomen at the age of 14 to 20 weeks of gestation. Then towards the end, there is a possibility of backache, edema, sometimes even insomnia and shortness of breath can happen. Then those are the symptoms of pregnancy, but the signs of pregnancy are cessation of menses. There is also a change in the consistency of the cervical mucus. Not only even that, by the way, there is a possibility of even frequent even infection of candida albicans, like vaginal candidiasis is actually very common because of the change in the pH of the vagina during pregnancy. Then I hope you recall what we have discussed in the spring semester. Then because pregnancy is one risk factor for vaginal candidiasis. There is also increased skin pigmentation, as I mentioned before. The skin pigmentation is as a result of increased the level of melanocyte or melanin pigment will be increased as a result of the hormone production. And also there is any changes, significant changes in the anatomy of the breast. And how do we confirm pregnancy? Mostly the urine human choriogonadotropin test is like the most. This is like one of the simplest tests which can be done from the urine sample. But sometimes when you are not very sure about the urine sample result and you suspect pregnancy, maybe do the serum HCG test. That is the confirmation. Then followed by a positive ultrasound. Even ultrasound can actually even show the fetus, and even fetal heart sounds and fetal movement can also be used as a confirmatory diagnostic test for pregnancy. Then how frequent we're supposed to do like antenatal care? Remember, in normal and complicated pregnancy, mostly like monthly visits or monthly antenatal care visit is important until the 28 weeks of gestation. Then after that period, between 28 to 30 weeks of gestation, now the mother is supposed to have a visit every 3 weeks. But then later, after 36 weeks of gestation, you're actually expecting even delivery or birth, then the visit should be done weekly. So this is actually the protocol even in the practice area. So if you initially start with monthly, then every 2-3 weeks, then after that, weekly until birth will be there. So during this period, they are going to check the blood pressure because of the possibility of preeclampsia and eclampsia is very common. Then they are going to look at the weight change and look at the urine protein and glucose, which can actually even happen. A glucose intolerance can actually happen during pregnancy, as we have seen in the previous several sessions. Then this is also they are going to monitor the fetal heart, and the fetal movement can also be examined. Then to add the most important point, what are the possible changes in the pharmacokinetic property of drugs during pregnancy? Remember, there are several physiological changes that can occur during pregnancy, but these changes can alter the effect of the medication and results in actually monitoring and even dose adjustment. So most of these changes usually began in the first trimester and they actually reach peak point during the second trimester of pregnancy. So what are the possible changes? Remember, the gastric intestinal impeding time usually increases. So because of that, it can actually even delay absorption and onset of action of some drugs. So this is one possible pharmacokinetic change. Because of the change in the cause of prolonged emptying time, now you are going to see those changes. So this ultimately affects the observation and onset of action of some drugs. And apart from that, the metabolic activity of some enzymes can be varied. Like for example, the activity of those isoenzymes of cytochrome 450 can be increased. So any drug substances that can be metabolized by those isoenzymes requires dose adjustment. Contrastingly, the metabolic activity of those isoenzymes will be decreased, so there is a need to reduce the dose to minimize toxicity. So you can actually even imagine how we need to be very cautious about even the dosing of drugs in pregnancy depending on the type of isoenzyme. So on drug metabolism, a pregnancy is actually having like dual effect, either increase metabolism or decrease the metabolism depending on the isoenzymes of the drug. Then there is also increase the maternal plasma volume and even cardiac output and even GFR by 30 to 50%. So because of that reason, sometimes it can lower the concentration of renally cleared drugs. So that is why sometimes dose adjustment is also very important with this class of drugs. Then apart from that, as body fat increases during pregnancy, then the volume of distribution of fat-soluble drugs may increase. So you can actually even imagine, like when the volume of distribution of the drug increases, means it will have actually longer half-life time in the body system. So there is a need to adjust the dose of fat-soluble drugs during pregnancy. Then apart from that, on the plasma albumin, it usually decreases the production of plasma albumin, so it can actually increase the volume of distribution. However, when the plasma albumin is actually like lower, there is also unbounded drugs that can actually increase clearance. So the net effect is very minimal on these kind of physiological changes. Then the hepatic perfusion like is usually increases. So theoretically, there is an increased elimination of the drug or metabolism of drug by the liver. Then apart from that, there is also pregnancy-induced increase in gastric pH. So this can even affect the absorption of weak acids and weak bases. But mostly what will be affected is the absorption of weak acids because of the possibility of ionization. Okay, then in summary, what are the major pharmacokinetic changes that can be happen during pregnancy? Like motility will be reduced. As a result, like the absorption will be reduced. The lung function will increase. The skin function will increase. The plasma volume, water volume usually increase. The protein levels usually decrease, but the fat deposition will increase. So fats or liver, but on liver activity, it has actually like dual effect, and the excretion on the GFR, the effect is usually increase or enhancement or increasement effect can be detected. Then another thing to note when we are talking about pregnancy is the transplacental drug transfer, which is very important. Remember, placenta is like any drugs, nutrients, and oxygen, and even those things are actually delivered to the fetus through the placenta. Remember, even for breathing, the fetus will not use its lung. They usually use the placenta, even to get oxygen, even to breathe. So it is actually a very vital organ of exchange for a number of substances. So because of that reason, and most of the drugs move from maternal circulation to the fetal circulation by diffusion, we need to be very cautious about some drugs. So remember, like certain chemical property of the drug, such as lipid solubility, molecular weight, degree of protein binding will influence the rate of transfer across the placenta. Generally, the lower the molecular weight, the easier to cross the placental barrier. So any drug substances above like 1 Dalton, 1000 Dalton, such as like the insulin and heparin, they will not cross the placental barrier. That is why we're using to manage gestational DM. Insulin can be used to manage, and heparin can also be used to manage DVT in a pregnant mother. So because they do have high molecular weight and they cannot cross the placental barrier in a significant amount and to cause adverse consequences to the fetus. Then apart from that, when a drug is actually lipophilic, like opioids, antibiotics, they can actually cross the placenta more easily than water-soluble drugs. So we have to be very cautious when you give lipophilic drug substances because of their ability to cross the placental barrier. Okay, then having said this much, let us talk about drugs as a teratogen. Remember, teratogen is any substance that can cause structural or functional abnormalities to the fetus or in the child after birth or as a consequence of maternal exposure during pregnancy. So mostly the risk is determined largely by the timing of that exposure. So the teratogenicity will be depend on primarily the time of exposure. Like if it is during the pre-embryonic period, we expect abortion. If it is due to the embryonic period, we expect fetal malformation. Then if it is exposed during the fetal period, we are expecting some kind of functional deficit. So what matter is like the time of exposure. So it is very, very critical. So based on the teratogenicity profile of the patient, drugs can be classified into different categories. I hope you have covered this issue in pharmacology. I'm expecting you when do we say a drug is pregnancy category A, B, C, D, and then X. So category A, there is control studies that shows no risk of harm. So category A is the safest. Category B, animal study shows no risk, but there is no control studies on pregnant mother. Still, it is safer to use. Category C, animal studies have shown some risk, but there is no control studies on the human being. So we don't know about the risk of the drug on the fetus. Category D is a high risk. It is highly actually high risk of teratogenicity. So there is a positive evidence of potential fatal risk. So before you initiate category D drugs, you have to measure the risk-benefit analysis. And mostly, category D drugs are used in pregnant mother, mostly in the life-threatening condition to the mother. If the condition is actually life-threatening to the mother, and we don't have an option, we have to use category D drugs. Category X is absolute contraindication. So this is just like non-teratogenic drugs such as thalidomide. Okay, then what are the general principles of treatment or drug use in pregnancy and lactation? So generally speaking, we need to avoid drugs that is non-teratogenic effect and to like to the infantis. We have to try to avoid as much as you can. Choose a single drug and short-acting therapy that have the longest safety profile in pregnant and lactating mother. That's the general recommendation. Now, we have to choose a drug with the following typical properties, like high molecular weight. Because the higher the molecular weight of the drug, like the lower probability of crossing even the placental barrier, even passage to the breast milk. A strong ionization. So the higher the drug to ionize, now the probability of crossing is very, very likely. Then high protein binding. The higher the protein bound drug, the probability is actually very limited, and high water solubility. So generally at the pharmacies, we are going to actually choose those properties are an ideal properties or an ideal drug to the mother during pregnancy and lactation. Then, apart from that, we need to counsel the woman to take the agent immediately after breastfeeding. Remember, she's supposed to breastfeed first, then she can take the medication. So the probability of actually having the drug concentration or like toxic drug concentration to the next feeding will be there is a possibility of having minimal concentration. That is why we need to counsel the woman to breastfeed uh, uh, before taking the medication. So those are the general principles of treatment in pregnancy and lactation. Then, like maybe some of the examples of drugs that are known teratogenic effect, like the ACE inhibitors. The ACE inhibitors are actually contraindicated. I think they're category X in pregnant mother. It can cause renal damage and growth restriction if there is exposure, especially during the first trimester of pregnancy. The barbiturates and the benzodiazepine, mostly they can cause neonatal withdrawal syndrome. Then the carbamazepine, which is an enzyme inducer and reduces the level of folic acid in the serum, it can actually cause neural tube defect. Mainly, we call it spina bifida. I hope you have heard about this one so many times, huh? Spina bifida. So there is actually a failure in the closure of the spinal cord. So as a result, there is actually some kind of like a tumor at the back of the spinal cord areas will be observed. So this closure is mainly due to the possibility of deficiency of folic acid. That is why when a mother is actually pregnant, they're supposed to be replaced with folic acid to prevent neural tube defect. And then some chemotherapeutic agents, they can cause multiple malformation. Even the misoprostol, apart from causing abortion, can cause even limb and central nerves malformation can happen. Then what about non-steroidal anti-inflammatory drugs in pregnant mother? Maybe let me break like for a few minutes and have interactive session. So what do you think about the possible risk of non-steroidal anti-inflammatory drugs in a pregnant mother? What do you think about the possible risk? Anyone who can try?
To the aorta. It's a main artery in the fetus. If it closes, it will prevent regular blood flow.
Okay, good. So what will happen if there is, like, what maintains the patency of the ductus arteriosus? What actually, like, what maintain, like, the patency so that it will be remain open, like, until delivery?
The prostaglandins.
The prostaglandins, exactly. So if when we give non-steroidal anti-inflammatory drugs, what will happen? There is a possibility of premature closure. So let me tell you something about ductus arteriosus. By the ductus arteriosus is a blood vessel that connects, like, the aorta, the largest the blood arteries, with the pulmonary artery. Remember, during pregnancy or during the fetal period, the fetus is not using its lung. So the lung is not matured. So lung is only utilized after birth. So that's the only time it will fill with air, and so that like the fetus or the infant can actually even breathe with a lung. But before that, it actually using the placenta even for getting oxygen and even for breathing. So this is how actually the human being made. So ductus arteriosus is a blood vessel that connects the pulmonary artery with aorta. Remember, pulmonary artery is like the type of artery that carries deoxygenated blood from the right ventricle to the lung. But since the lung is actually not matured and the system is actually blocked, so there is a direct connection between the right, like the pulmonary artery to the aorta, so the blood will go directly to the circulation without reaching to the lung. So this is how the fetal circulation look like. So that patency can be maintained by the use of, by the presence of endogenous prostaglandins. So it actually relaxes so that it maintains the patency. But the major problem with the use of non-steroidal anti-inflammatory drugs during pregnancy, specifically in the second and third trimester of pregnancy, it can actually cause premature closure. So this premature closure can actually even causes a problem to the fetus, specifically by increasing pressure in the left ventricle. So if that patency is closed, even the fetus can actually even have a heart problem. But that is the major problem why we are not using NSAIDs during pregnancy. But sometimes even, like, in principle, those patency is supposed to be closed after birth. Like in the few days after birth, it will be closed. But in some individual, it will actually even remain open. So remember, after birth, it remains open means, like, there's a mix-up of oxygenated and deoxygenated blood, and there is a possibility of actually problem on the lung and the lung and the heart of the infant. So we need to maintain the patency during gestation, and it is supposed to be closed after birth. So in general, NSAIDs are generally not recommended in pregnancy because of the possibility of premature closure of the patency of ductus arteriosus. That is the main one, but they can actually even cause hemorrhage, as you said before. Okay, then I hope the rest you know about phenytoin, and we are going to discuss in detail as we reach in the next semester. Phenytoin, it can cause like cleft palate and cleft lips, can actually even happen. Tetracycline, tooth mottling, I think this one, I think you have discussed it when you are discussing about antimicrobial agents. Then valproic acid, thalidomide, I think you know this one, the well-known teratogenic medication, but we are still using it in treatment of cancer, mainly in multiple myeloma. This one we'll discuss it in an oncology area. Then the valproic acid, what we don't like, this mood stabilizer, is the possibility of neural tube defect because it affects the absorption of folic acid. Then warfarin, what we don't like with warfarin is the possibility of fetal hemorrhage, growth restriction, and even CNS malformation can happen. So I think the whole tech message for this session is like what is expected at the pharmacies. Like the assumption is the pharmacist is a drug expert. So we're supposed to give us like proper pharmaceutical care service for our patients as well as to the other health care team. But because like the medics are very busy in doing the diagnosis, not about the drugs, so we have to keep on like updating them, especially in drugs. So we're supposed to know which drugs are contraindicated and why in pregnancy and lactation. Okay, then I think this one is still a continuation. Maybe you can read. Then some drugs are not recommended when during lactation. So these are some of them. You can actually even read because the list is not exhaustive, and like the whole idea of talking about this topic is just to give you awareness about the possibility of teratogenicity profiles of drugs. Otherwise, like have to keep on updating as we move on. Then let me take you through about the possibility of preconception care of antenatal care. So remember, all women of childbearing age, they are supposed to be counseled on appropriate dose of folic acid to prevent congenital anomalies. Like I think maybe some of you are aware about the possibility of iron folic acid supplements. They call it even IFAS. Some physicians, by the way, they prescribe like IFAS. Sometimes you are struggling to know what does IFAS stands for, because like most of us, we're not very like convenient. We don't really like use of abbreviation with a prescription specifically, but you'll see a prescription of IFAS when you see a pregnant mothers. So this one is iron folic acid supplement, which is very important. So why we need to give iron folic acid supplement is during pregnancy even, the mother is actually even producing like more blood vessels, like more blood cells, sorry, more blood cells to prevent, like to give, to prevent even the possibility of anemia, and because of the share with the fetal or the fetus, so more blood is actually, my blood cells are formed. So because of that, there is a possibility of folic acid and iron deficiency during pregnancy. That is why all women of the childbearing age, they are supposed to be given like 0.4 to 0.8 milligram or 400 microgram folic acid supplement should actually be given on the daily basis, mainly beginning 1 month before pregnancy through the first 2 to 3 months. But the risk of neural tube defect is very high in the first 2 to 3 months. That is why there must be a continuous supplement of this supplement in the first 2 to 3 months. But beyond that, the probability is very minimal. Then, especially for high-risk mother, like if the mother is actually high risk of neural tube defect, like maybe a previous child, a first, second, third degree relative with neural tube defect, and those patients with epilepsy. Remember, most like the carbamazepine, the mood stabilizer, anticonvulsant medication, and the valproic acid, those are the most common medications. The medications that have been used to control seizure, but will come in the next semester. So this class of drugs, the major problem is actually, especially the carbamazepine, it is an enzyme inducer and it can increase the metabolism of folic acid and it causes folic acid deficiency. So as a result, what will happen if the person is actually, if the mother is not taking a supplement, what will happen? There is a possibility of neural tail defect. Remember, there are two types of neural tail defect. One is spina bifida, the other one is anencephaly. That means like the skull and the brain is not actually formed with the proper size. So, but this one is mainly causes spina bifida. So in high-risk patients, 4 milligram of folic acid on the daily basis are usually recommended. So I think that is something I want to share with you. So that is very important. And the duration is the first 2 to 3 months, preferably before conception. That is the recommendation, but that is not very practical, but we have to continue at least for 2 to 3 months duration. Then secondly, what are the common conditions in pregnancy? Remember, nausea and vomiting is very notorious, especially in the first trimester. I think you can actually even liaise with your mother how nausea and vomiting is actually very, very bad during this period. And as a result, even they don't eat, they can actually even very severe, and I will come later in detail. Then constipation is also very common, and including even hemorrhoid. So as a result of reduced motility of the GIT, constipation is very common during pregnancy, sometimes even after delivery. Like this is a very common condition. So we have to know how we're managing this condition because we'll encounter several cases. Then a possibility of heartburn. This is actually because of the relaxation of the lower esophageal sphincter. Remember, like this is stomach. So when there is relaxation of the lower esophageal sphincter, means it will not actually even close properly, so that there is a possibility of acid reflux and causes heartburn sensation. Yeah, that is, we call it heartburn sensation. So those are very common conditions, and we are the pharmacists supposed to know how we're managing those conditions. So the general principle is still treatment of prevalent condition in pregnancy and lactation. Whenever possible, treat condition occurring during pregnancy with non-pharmacological therapy instead of using drug therapy. That is the general recommendation. Then assess the need of the treatment and evaluate the risk benefit. That is very, very important point is to note. Then avoid treatment that do not show evidence of benefit. Or sometimes there is a possibility to delay the treatment until delivery. Yeah, that is also. So we need to like check every parameter. So we at the pharmacists are the front line, especially in like capturing those common mistakes because we are the one who is handling the prescription. Like at the end, after everything has been done, we are the one who is supposed to deliver or dispense the drugs to the patient. So we have to check. But of course, because of the patient flow, the probability of checking each and every point is not possible in majority of the public setting, but some, like most of the private sector, like the private facilities in Kenya, I think they tried because they do have like those things. Maybe if you visit Aga Khan, if you visit Gertrude, what else? Huh? I think those are the places I visited. So really, frankly speaking, they really deliver good pharmaceutical care. Yeah, good pharmaceutical care, and you'll see like the real role of pharmacies in that facilities. Okay, then. Management of nausea and vomiting. Let's see about how we are managing nausea and vomiting in pregnancy. Are we going to use like the medication we are going to see, like the antiemetics we have seen in pharmacology class? So, or which antiemetic medications are safe in pregnancy? I think that is the point of discussion. So we have mentioned before SCG, the one that causes nausea and vomiting in pregnancy, which is produced by the placenta. Like you can actually even see the epidemiology, as many as 85% of pregnant women suffer from nausea and vomiting. So nausea and vomiting is very common in our respective home when our mothers are actually, when our mothers are pregnant. So how do we, what do we do? Like, what is the role as a pharmacist? First line treatment is still non-pharmacological. Lifestyle, rest, avoid any triggers. Huh? Because if you see in some kind of pregnant mother, they do have triggers. So if they know the triggers, try to avoid. Then apart from that, dietary changes, that is very important. Small, frequent meal, fluid restriction during meal, avoid spicy or fatty food. Those are very important conditions that is advisable during pregnancy. But sometimes it can be beyond like the first line treatment approach that is non-pharmacological, and we are in a position to use antiemetic medication in pregnant mother. If so, what are the first choice? The combination of pyridoxine is vitamin B6. It has a role to control nausea and vomiting. I hope you know pyridoxine. Where do you know pyridoxine, by the way? Where do you know pyridoxine? Okay, Noor, can you try?
Yes, sir.
What is pyridoxine?
I can't remember.
Can I try?
Yeah, please do.
I remember we were giving it with isoniazide because it causes neuropathy.
Okay, yes. Why it causes
Peripheral neuropathy.
peripheral neuropathy? Yes. Okay, good. Can we use, by the way, if you remember in the previous class, we have discussed about the neuropathies in diabetic patients, which can be treated with amitriptyline, pregabalin. Can we use to treat peripheral neuropathy that is induced by NH using amitriptyline? Can we use? Like in case, if a patient is actually having like INH in these peripheral neuropathies, so if we don't have vitamin B6, are we allowed to use amitriptyline? So what do you think? What do you
I
think?
don't think so.
Why?
I don't know.
Oh, but you don't think so, but you don't know, huh? Okay, good. Okay, any other person? Okay, in short, we don't use because the pathogenesis here is like what causes peripheral neuropathies as a result of depletion of vitamin B6 secondary to INA. So we have to give pyridoxine. Remember, pyridoxine, vitamin B6 are very important for the development of peripheral nerve system. Okay, fine. So when you see INH prescription, make sure you have to check pyridoxine 25 milligram. But don't give pyridoxine too much. If you give them, it can actually even cause peripheral neuropathy by itself. So like optimum dose of pyridoxines are very, very important. Okay, then doxylamine is the first generation antihistamine. Now we are going to see, I'm going to take you through about antihistamine when you are discussing about the frontline medication. So generally, if you see a pregnant mother suffering from nausea and vomiting, and if you are not able to control with non-pharmacological treatment modalities, now the first line medication, which has a long-term safety data and show no fatal risk with this is combination of pyridoxine and doxylamine. It is available by the locally, and this is the most commonly used medication even in Kenya too, in managing nausea and vomiting in a pregnant mother. When this combination is insufficient, now we can try the placid, which is the dopamine blocker, and the diphenhydramine, and even ondansetron, the serotonin receptor antagonist. Still, they do have some safety profile, but they are not the front line. So second line pharmacological treatment, generally speaking, like first generation antihistamines are more safer than second generation antihistamine in pregnant mother. So if you are being asked which antihistamine to use in pregnant mother, maybe use diphenhydramine will be the preferred. But in case if you don't have diphenhydramine, you can use other generation antihistamine, but it should be in the first generation. It is more safer than second generation antihistamine, but still there is limited evidence. What is safer so far is pyridoxine and doxylamine, but generally first generation antihistamines are safer in pregnant mother. But we can use dopamine antagonist and serotonin antagonist like ondansetron. But remember, there is a limited data that addresses the safety and safety issue of those drugs as compared to the first line drug. So this is usually used when the first line drugs are not working and when it is not available. Remember, antihistamines can cause drowsiness. Is there anyone who has taken cetirizine before? This is actually even part of the COVID treatment regimen. I don't know whether you are aware about COVID treatment management. So why we use cetirizine, or why cetirizine causes drowsiness, or why antihistamine causes drowsiness? Okay, maybe I will ask you next time to go and check why we use cetirizine in COVID patients. What is the rationality to be? What is the rationale to use antihistamine in COVID patient? Okay, Bosibori, can you try?
Yes.
Can you try why antihistamine causes drowsiness? For sure, you have covered it before, because this is under GIT pharmacology.
Yeah.
So what do you think?
I'm not so sure.
Okay, if we do have diphenhydramine and cetirizine, which one is more causing sedation?
Is it cetirizine?
Okay, why?
I'm not so sure.
Okay, good. Can you maybe you ask someone? Huh? Can you pass the question to someone?
Njeri.
Injury, okay? Injury. Those things, by the way, you have to know. Those are like common sense questions. You cannot miss it everywhere.
I think the first generations are the ones which have more drowsiness effects than the second generation because it passes the CNS.
Okay. Good.
So, is it because it causes the blood-brain barrier? So that's why it's causing the CNS side effects.
Yes, actually, it crosses the blood-brain barrier and it causes CNS side effect. But anyways, antihistamines, the first generation antihistamines, as we go down to the generation, like the possibility of drowsiness or side effect generally decreases. First generation antihistamines are more sedating than second generation. Remember, like the cetirizine, levocetirizine, fexofenadine, they are second generation antihistamine. So they do have low risk of sedation, but still they are sedating. Like if you are comparing diphenhydramine with cetirizine, this one is more sedating than cetirizine. So why they causes drowsiness? Because histamine has a role in arousal. So the moment you are blocking the histamine receptor, the patient can be drowsy.
So, it means that in pregnancy, it's safer to use the cetirizine, not the diphenhydramine.
No, the diphenhydramine, still we can, I will come actually the next slide. Diphenhydramines are like still the second generation, still in the second line alternative in terms of safety. We're actually looking about in terms of safety to cross the placental barrier and causes adverse effect. So we can still use cetirizine, but more data is available on second line. But still cetirizine is actually part of like the treatment if we don't have an option. But so based on the available evidence, for this one combination, we do have long-term sub and there is no fatal risk. This one is still limited. So if we don't have an option, we still use. But generally, first generation antihistamines are more safer than second generation, such as histamine, cetirizine and levocetirizine. So if we do have both, and if we're supposed to choose for pregnant mother, I will go for diphenhydramine because it is more safer to the fetus despite the drowsiness. So what you can do, by the way, if a drug is actually causing drowsy, it gives them at night. But sometimes even if that is not sufficient, because sometimes in the morning hours, some people will having difficulty to wake up because of the drowsiness effect. So they can actually even take in the late evening, like maybe around 5, maybe 4, then they will take in the late evening, then they can actually slightly reduced, like they can be slightly protected by the morning drowsiness. So that's the general recommendation. Okay, any questions so far? So are we together? So this is the dosing. Yeah? I'm not very strict about like the dosing at the moment, but because like no one is very perfect in dosing, so it is just like an experience. You learn the doses by experience, but it is good to check to know at least like the common doses. Like diphenhydramine, hydranate is still first generation antihistamine, doxylamine, 25 to 50, like QID, pyridoxine 25 milligram TDS. The combination can be given like 2 pills at the time, or maybe 1 pill in the morning, 1 pill in the afternoon, plus hill and ondansetron. So those are the drugs that can be considered in the management of nausea and vomiting in pregnant mother. But this one is the front line in the management. That continue this one, then we can actually even use this one. Ondansetron is a serotonin receptor antagonist, so 4 to 8 milligram TDS can be used. Then now, hyperemesis gravidarum. I don't know whether you have encountered like very severe form of nausea and vomiting in a pregnant mother. Is there anyone who came across a very severe nausea and vomiting in a pregnant mother? Anyone? Okay, fine. So sometimes it happens. I think I have seen few patients who are actually having very severe. That is the worst problem. So like in severe persistent nausea and vomiting during pregnancy, we call it hyperemesis gravidarum, which is combined by dehydration. As a result of vomiting, you will see even electrolyte disturbance and weight losses. The exact cause is not known, but it is thought to be due to the high level of the hormone, and usually appear between week 4 to 6 weeks of pregnancy, and it reaches to between week 9 to 13 weeks of gestation. But it is different from morning sickness. By the way, morning sickness is very common condition, and the name comes because it happens mostly in the morning, but it can happen at any time of the day. So, but this one is very mild. It's usually nausea. Sometimes there is a vomiting, but most of the time the morning sickness is actually having nausea. So, but it usually subsides after 12 weeks of gestation, or the vomiting does not cause severe dehydration. But in case of hyperemesis, there is nausea followed by severe vomiting, and the vomiting and the nausea does not subside, and it can actually even cause severe dehydration. And we're supposed to actually treat. Remember the risk of dehydration, renal shutdown, then the patient will die. So how do you manage this condition? There is no known prevention strategies. So mild cases can be treated with dietary changes, rest and antacid. But if it is severe, we have to give IV fluids, electrolyte, vitamin, and nutrients. So that is very important. Remember, when a patient is actually having severe vomiting, even there is a possibility of metabolic alkalosis, because like the hydrochloric acid is actually like removed by the vomitous material. So there is a possibility of having that condition. And NGTO feeding to restore, and even IV ondansetron can also be considered in this condition. So that is in short, in hyperemesis condition, I have to consider IV rehydration treatment, and IV antiemetic therapy can be considered. Then how do we manage constipation in pregnant mother? Remember, what causes constipation is because of increased level of progesterone. Progesterone slow motility and relaxed esophageal sphincter, and even causes edema. As a result, the patient can have constipation. As a result of relaxing of the lower esophageal pressure, there is a possibility of heartburn and rhinitis. So how do you manage this condition? Still, non-pharmacological treatment is the mainstay of treatment. What we advise a high fiber diet, drink plenty of water, avoid rices, white rice and cheese. They're actually notorious to cause constipation. So that is the non-pharmacological treatment modality. If it doesn't work, we can actually use bulk forming laxatives. I hope you have covered about the laxatives. The calcium and xylem products can be safely used in pregnant mother. We can also use stimulant laxatives such as bisacodyl. I think this one is the most widely available drug I have seen in the local market. Like from the laxatives, this one is the most widely available, bisacodyl. It is available in the form of suppositories, also in the form of tablet. Okay, so those are the alternatives. So the first line medications are like the bulk forming laxatives, the first line medication. So if it doesn't work, we go to bisacodyl, 5 to 10 milligram orally or rectally. Yeah, that is the recommendation how we're managing constipation. But remember, still non-pharmacological approach will be the first line treatment modality. Then I don't know whether you heard about hemorrhoid. Have you heard about hemorrhoid? Have you seen anyone who is suffering from hemorrhoid? Anyone who came across this condition?
So does this happen because they get constipation?
Yes, constipation is actually one cause because they're supposed to strain like for a long period of time in the toilet when they're having constipation. So this actually causes like increased venous pressure. Yes. Is there anyone who came across this condition? I think this is very common, especially like the someone who is actually sitting for a long period of time because of increased venous pressure to the lower anal sphincter causes inflammation, irritation, ultimately even bleeding. That is very common. So soaking in warm baths also may help to relieve from hemorrhoid and relaxing the anal sphincter. Sometimes even surgical resection can be given. Yeah, icing the area may decrease pain and inflammation, but if hemorrhoid is severe, surgical resection and banding can be performed. But there's a drug that is important, anusol. Let it be smooth subgallate. Yeah, anusol is the most commonly used drug to prevent inflammation in the area. It is available in the form of cream and suppositories to manage hemorrhoid. Okay, then finally, how do we manage heartburn in pregnancy? So non-pharmacological is still the leading treatment modalities. Eating small, frequent meals, remain upright after eating is usually recommended, and avoid food that is known to decrease lower esophageal sphincter tone, like chocolate, coffee, fatty food, and peppermint. But then, I don't know whether Dr. Larry has mentioned when he was discussing about gastroesophageal reflux disease. So even in that condition, we are supposed to avoid those like food items because they can lower the esophageal sphincter and it allows the chance of like a reflux of acid to the esophagus. Sometimes even actually it goes to even the tongue, and we feel even the bitter taste of the stomach acid in the mouth. Yeah, it can happen even up to that level. So in general, it is advisable to avoid those food items because of this tendency. And how do we manage heartburn? Remember, managing heartburn is mostly acid reflux. So we give them what? Antacids are generally recommended. So calcium and magnesium containing antacids are the first line therapy in heartburn in pregnancy, but aluminum containing try to avoid because of the possibility of fetal neurotoxicity. So if this fails, what we can do is we can use ranitidine. But okay, of course, ranitidine is no longer in the market. It's already recalled. Did I mention this one? No, I think I mentioned with a P0 student. Have you heard about any breaking news about ranitidine in the market? Have you seen ranitidine? I think it's already even recalled in the Kenya market. Sorry, I forgot to update like the slide. Okay, anyways, it is actually recalled by FDA because of carcinogenic material was obtained with long-term storage. I think it's no longer in the market, but I'm not very sure. But it is in the late, it is in the early 2020, somewhere in January, February, somewhere that was recalled in the market. Is no longer in the market. Even currently, by the way, I've seen yesterday about metformin. Metformin is also like in the US, it is recalled because of teratogenic material like substances produced after some time. Maybe you can read the news. You can actually read the news. This is one of the most commonly used drug, but it's recalled recently, like yesterday or like 2 days ago. I keep on updating those information because there's a lot of dynamics like in treatment anyways. Okay, I think it's officially recalled in the US like 2 days or 3 days ago after we conclude the session. Okay, generally, if ranitidine is like the safest in pregnancy, because although most H2 blockers are safe in pregnancy, ranitidine is the only agent with double-blind randomized trial. So like we do have at least sufficient data from H2 blocker, but H2 blockers are generally they are safer in pregnancy. Okay, then what other pharmacological agents can be used to treat heartburn in pregnant mother? We can use proton pump inhibitor, sucralfate, and placil. So by the from the PPI is actually the PPI with the largest body of human safety data during pregnancy is omeprazole. We do have like the largest safety of data about omeprazole as compared to other PPIs. So we can use. Do you know why we use metoclopramide in the management of heartburn, despite it is antiemetic? Why we use Placil in the management of heartburn?
Is it because it will enable food to go down so the reflux won't go? There won't
Okay.
be reflux.
Thank you so much. Because it has prokinetic effect, it actually promotes GI motility. Prokinetic effect. So it actually even like counteract the effect is what we have seen with the chocolate. Okay, fine. Because of that, it can be even used to manage gastroparesis in the patient. We call it autonomic neuropathy in the patients are also very common, despite I didn't cover everything. Yeah, gastroparesis can be treated even with Placil because of the prokinetic effect. Okay, then. Then this is the dosing schedule. I think you can actually even read this one, like the antacid. We do have like the terms, Malox. I think the term is the calcium carbonate. The Malox is aluminum, is it aluminum, calcium? You can actually check what is available in the Malox. Okay, then omeprazole, we can use 20 milligram, ranitidine 150 twice daily. So Sucralfate, I think you know this one. It's actually like mucosal protective drug. Is like it actually coat the mucosa so that it prevents damage from the acid. Then the common cold management in pregnancy. How do we manage common cold in pregnancy? In fact, most of us, we don't bother about common cold, but some common colds are actually very notorious. So it can actually even cause a lot of things. So rest fluid and nasal salines are usually recommended. But if there is actually nasal congestion, maybe we can use nasal congestants like oxymetazoline can also be used, oral guaifenesin and dextromethorphan. Those expectorants can be considered. Okay, but the major problem with nasal decongestants are actually the possibility of rebound congestion. We call it like rhinitis medicamentosa, like rebound congestion after like stopping of the medication. So that is a major problem. But generally, we can use those things in pregnancy. Oral pseudoephedrine can also be unacceptable, but the major problem is avoiding the first trimester because of the risk of gastro cases. So this is actually like the intestine will come out. That is the side effect of pseudoephedrine in the first trimester of pregnancy. So it is like the last option. How do we treat allergic rhinitis in pregnant mother? Mostly the recommendation is nasal corticosteroids are usually recommended during pregnancy. I don't know whether you came across with nasal corticosteroids. Is there anyone who came across with this class of drugs? Nasal corticosteroids. Okay, so from this, budesonide is the safest to treat in case if there is allergic rhinitis in pregnant mother. If antihistamines are supposed to be used, chlorpheniramine is preferred due to its record of safe use during pregnancy still from the first generation. But we do have pure data available regarding the safety of second generation antihistamine during pregnancy. I mentioned before, first generations are more safer than second generation, so we can use the first generation to manage rhinitis. Okay, then there is also animal and human studies seem to suggest overall safety for cetirizine and loratadine. However, guidelines recommend their use only in women on topical steroids therapy who are unable to tolerate chlorpheniramine. There is some kind of evidence, but still we can actually even usually used when the patient is not tolerating the first line medication. Okay, so we can have an option, some safety data, but still we are actually relying on the first generation antihistamine. Okay, so this is the summary. I think you can read this one. And finally, how do we manage pain in pregnancy? Remember, pregnancy and lactating women experience a lot of pain from pre-existing condition. So how do we manage? Mostly The maximized non-pharmacological measures can be considered, but acetaminophen is the safest analgesic during pregnancy. Like if the mother is supposed to take epi medication, she can actually take acetaminophen, is the safest of all analgesic drugs during pregnancy. So we advise for a mother to take as much as she can, try to avoid, but if no option, she can use acetaminophen when necessary. If medications are required, avoid NSAIDs during the third trimester, as I mentioned before. Yeah, avoid any use in second and third trimester. If no option, maybe ibuprofen can also even used in the first trimester. But remember, there is a possible risk. Some literature said like opioids are not associated with high risk of malformation, but still there is a possibility of neonatal dependency and neonatal respiratory depression. Yeah, what we feel with opioid class of analgesic is the respiratory depression, and ultimately they can actually even cause this. That is why some people are actually even injecting high dose of like PTDine, then they actually cause this because of respiratory depression. I think you remember, like did in 2017, like a doctor from KNH just passed away because of high dose of PTDine. Okay, anyways, also there's also an evidence a small dose of codeine is acceptable, yeah, in severe cases if the patient is not responding. That is also one option. Yes, that is also one option. So yes, ibuprofen, those are NSAIDs, by the way. They are second line, but in the first trimester only. Yeah, second line in the first trimester only, because the possibility of closure will be very high during the second and third trimester. But generally avoid use of NSAIDs apart from paracetamol in pregnancy. I think that is like my home take message about this topic. Any questions? You are welcome.